for constant rate infusions. So a little bit of backstory about me. I was actually born and raised in White Lake, Michigan, attended Michigan State University for both my undergraduate degree and for veterinary school. And then I meandered my way down to Indiana, checked out IndyVet, was quite fond of it, started a rotating internship, completed that, and then they liked me so much, they actually kept me on, and I liked it so much, I decided to stay. And the point of why we're here today and why I chose to do this topic is actually because of metoclopramide. We had many instances of technicians and doctors having issues setting up a constant rate infusion. And we'll get back into that later, but that's ultimately the reason I elected to do that here today. So, constant rate infusions, what are their purpose? Well, they've been used a lot more in human medicine, and now they've actually picked up pretty largely in veterinary medicine more recently, largely for analgesia or pain. They've also been used as a sedative agent, whether using something like dexmedetomidine. We also use it like dextrose for our hypoglycemic patients. We have insulin for our diabetic ketoacidosis patients. Also metoclopramide for our patients that may need it for different GI-related disease. Generally, constant rate infusions are used via intravenous administration, though there are other methods for that. But also, why is it important? Why are appropriate calculations important? And each of us chose to go into this field because we care for our patients. They deserve the best, and our goal is to provide quality care and medicine. A single miscalculation could cost their life, and that's something that we can't afford. And so by learning how to do these appropriate calculations, we can give our patients the best care. Additionally, it's important to feel comfortable and confident. And I know even in our clinical setting, we have technicians and doctors that have to go to the head techs to appropriately set up certain CRIs. It can be more time efficient if we know how to calculate and set these up appropriately, and that way it gives you the independence and the confidence to do it yourself. So the objective today is to create that confidence. This lecture is going to cover the fundamentals of constant rate infusions. We're going to establish the basics of pharmacokinetics behind the infusions, discuss pros and cons about CRIs versus intermittent therapy. And then we're going to move on to calculations, including some drug doses, conversions, dilutions, and then practicing the actual calculations for constant rate infusions that you may use in a clinical setting. I will forewarn everyone, this is pretty dry substance, and I can't get around that. However, we can all suffer through this together. And I've also added quite a few cute puppy and kitten pictures along the way to help. So first is pharmacokinetics. Before we discuss the functional purpose of constant rate infusions, we're going to cover pharmacokinetics, pharmacodynamics. Pharmacokinetics is about drugs and their absorption, distribution, metabolism, and excretion in relation to the body. Really, it's what does the body do to drugs? And in this case, drug, we're using it kind of interchangeably with chemical, medicine, therapeutic. It is a substance that we're administering to a patient for a desired effect, and that will come at a dose. A dose is the amount of substance administered at one time to achieve the desired effect. Dose generally we're going to be thinking of in milligram, gram, mil, microgram, one of those amounts. The first step of pharmacokinetics is absorption. There are different routes that we can administer medications. We have enteral, which is basically we're giving it through the mouth, and generally that's going to be absorbed through the gastrointestinal tract. We commonly use that because it's easy. It's generally safer because we're not needing as aseptic technique as some of the other methods. There are some downsides to it in that it tends to be a little bit slower, and also it requires the absorption through the GI tract, which can have different effects, whether it's first pass through the liver. Also, we need to make sure that it has the right pH for that absorption. But then there's also parenteral administration, which will be kind of the other methods we think about with IV, IM, sub-Q, and some of the other ones. And these methods are helpful because generally they're going to be more rapid and they can increase our bioavailability. So IV is one of the most common that we use and which we're going to be talking about today. And it ensures effectively 100% bioavailability because we are administering it right away. Now, moving forward, we talked about absorption, which is the movement of a substance or the transfer of a drug from the site of administration into systemic circulation. In this case, we're going to be seeing on our nice little picture here, by absorbing the drug, we're actually getting it into effectively our bloodstream, because the bloodstream is, for the cardiovascular system, is like a highway that allows the rapid transfer of that drug from the site of administration to wherever our target site is. We can see that this is either going to show up as a free drug or a bound drug. Bound generally are going to be to protein like albumin or other things that it may bind to. It can also accumulate in tissue, and it can also go to our action site. Distribution includes that drug that does move to more of the extracellular spaces or into the tissues. And then metabolism and excretion are going to be performed either by the kidneys or the liver generally, which kind of involves into our elimination of a drug. So the way that we think about a drug interacting with the body is going to be how much it is within the body, and that's usually a function of the absorption minus the elimination. And the amount that is free or unbound that we see here is going to be relatively somewhat like our active form and our active drug or substance. Now, moving into pharmacodynamics, that is kind of the inverse of pharmacokinetics, whereas pharmacokinetics is what does the body do to drugs, pharmacodynamics is actually more of what do chemicals do to the body. In this case, we're going to focus on specifically that plasma drug concentration. Drug concentration at receptors, which is where we get the effects that drugs give us, we generally aren't able to measure at the receptor site, but we can measure how much of this substance is within the blood. So that's our surrogate here. So that's the important factor that we want to keep in mind. Generally, we want to keep that plasma drug concentration within our therapeutic range. So that's going to be between our level here that would be subtherapeutic if our plasma concentration is too low, but make sure it's not getting up here above our toxic range, in which then we can have more severe side effects or toxic effects. So we want to stay right in that nice therapeutic window or therapeutic range. Now, there are different ways to do this. More traditionally, if we give an injection of a medication, we can think of that as a bolus or a loading dose. And the goal is to try to bump us up into that range. If we did it another way, where we just threw them onto something like a constant rate infusion, it would take about 5 half-lives, and the half-life is the estimated time that it takes for plasma concentration to decrease by about 50% of the original value. So by combining these two together, though, we can use these dynamics for constant rate infusions. So the advantages here is that, as we can see on all of these lovely graphs I've added, if we give a bolus, we have a risk that we could bump up, and then eventually that's going to start wearing off. It's going to start going down, and we can actually become sub-therapeutic. With constant rate infusions, the goal is we first want to get up into this range, and we want to maintain that by giving that constant, consistent rate of the medication. It can help avoid the sudden peaks and troughs that we do see with intermittent bolusing, and bolus therapies do lead to that relative rapid, it can rise in our concentration. It can lead to adverse effects. It's also possible that if we start seeing adverse effects at these doses, we can start decreasing them, and that way we're using a lower dose at a time consistently, as opposed to giving these larger boluses intermittently. In painful patients, this has been observed to help reduce breakthrough pain by keeping their pain control consistent. And it's actually been shown that we can reduce the total cost to the patient, and we can reduce the total suffering of the patient, and we can also reduce the total amount of drug that we have to use in these guys as well. Now, there are some disadvantages to using a constant rate infusion. First of all, it's going to require an IV catheter because that's generally the way we're going to be using these. And you're also going to require hospitalization for constant administration and monitoring. Also, we need to prepare a solution. So generally, when we're getting these together, we're either using a syringe pump or we're using a fluid bag. But either way, we need to get a larger amount of prepared solution ready, and we need also some more equipment. So that equipment cost may be something that the clinic doesn't necessarily have. And so that is something that we can see some syringe pumps costing a few $1,000s just in the initial cost. And then, of course, there's upkeep costs as well. The other thing we need to keep in mind is if we're using constant rate infusions, we may or may not be mixing medications. And that just comes with a greater chance for error because we need to be very pertinent and conscientious of which medications we are mixing to make sure that we're not inappropriately putting those together and causing precipitation in our line and danger to our patients. I just wanted to briefly cover on fluid bag versus syringe pump therapy, kind of contrasting those two. Fluid bags are very helpful that we use sometimes with lidocaine, morphine, sometimes fentanyl, metoclopramide. They are very advantageous because we have less equipment. So instead of having a full fluid bag pump and also having a syringe pump and a lot of things that are cluttering up near the patient and a lot more things to work with, you have a single pump that you're using that's administering your medication, and you have less room for the syringe pump malfunction itself. There are disadvantages, though, in that you are limited by the total intravenous fluid rate of your patient. So if you put morphine into your fluid bag, you're probably going to have to keep that relatively a similar rate if the patient's fluid intake for that day is going to be based on that fluid bag. So if you have them at maintenance and you can't go far above that, you can't increase your pain control if you're using something like morphine. Additionally, you're going to be drawing up a larger volume. So it's not good if we are kind of going for a short-term therapy potentially, because you may end up with a lot of unused medication. Syringe pumps, on the other hand, can be very advantageous. They're rapid and simple, and they can be relatively independent of your intravenous fluid rate. And they're somewhat easy generally to pick up and use. There are disadvantages, though, in that they are reliant on the carrier flow. So somewhat similar to the disadvantage of the fluid bag is if you have a very small patient whose maintenance fluid rate is your 1 kilogram Yorkie who gets 2.5 mils an hour, just the distance from your piggyback that your syringe pump is coming in on, that distance may take half an hour to even get to your patient. So you're very much reliant not on just the fluid pump, but also on the fluid bag pump for getting that fluid to your patient. As I said before, it's also more equipment, so it creates more clutter. It's going to be more money. So those are things that a clinic does need to keep in mind. But the one thing I did want to touch on, which I did find in my research, is the variable responsiveness. And so actually the FDA did put out a warning of serious risk, specifically with syringe pumps and their use and potential occlusion causing inappropriate administration of medications in pediatric patients. Now, this is in pediatric patients. This wasn't from veterinary medicine, but we can somewhat infer it for some of our smaller patients. From March 2013 to July 2016, the FDA did receive over 300 medical device reports associated with syringe pump use in these situations that had to do largely with a distal occlusion and the amount of time it took for the alarm to sound that there was an occlusion. And they found with higher fluid rates and smaller syringe sizes that we had generally a quicker response time, whether it was 1 to 2 minutes or 3 to 5 minutes. But with the 60 ml syringes, it took over half an hour until it even alarmed, and that was at 5 milliliters an hour. And at fluid rates of 0.2 milliliters an hour, none of the pumps had any alarm despite 30 minutes of distal occlusion, and that was regardless of size. So I know that's a lot of info, but the big thing we want to take from this is if you're using a syringe pump, you need to be very pertinent about what size syringe we're using and what your fluid rate is. And here I have just kind of the takeaway that they had was there's a quite serious risk if you're using less than 0.5 mils an hour, and there is a increased risk if you're using less than 5 milliliters an hour. And of course, they also recommended decreasing the sizing with the biggest risk at the 60 milliliter syringe size. So looking forward, these are things that you want to make note in your hospital so we can try to reduce those potentially affecting our patients. Talking about setting up a constant rate infusion, the first step is determining what medication that we're going to be prescribing. And so with that, that's really going to be determining, what we're adding to our solution. And that'll help determine if we're using a fluid bag or a syringe pump. We also need to use an IV catheter and start thinking about, are we going to need a peripheral or central for this medication we're using? If we're going to be giving high volumes of dextrose or other, hyperosmotic substances, it's generally going to be better to use it via a central line versus some other things that should be fine in a peripheral line. We want to make sure our materials and equipment are compatible. So that would be, if you're using a syringe pump, you need to make sure that your syringe is compatible with that pump. I know I've been yelled at by a machine a few times because I was hitting the wrong setting for the BD versus Tumoro syringe. And then when we're preparing our solution, we need to make sure that we prepare it appropriately. But we're humans, and we can make mistakes, but we help bypass that by appropriately labeling them because it gets us thinking about it. So on the left here, I have what would be almost in a completely appropriate fluid bag that is labeled for 2.5% dextrose. We always want the drug name, whatever we're creating, the date it's created. I did black out the individual's initials, but you always need to initial it so we know who made it, so we can always go back to the source. You want what the bag concentration is going to be. So in this case, we've made a 2.5 dextrose solution, and you want what you added. And the key here is we all can, in our process of making these solutions, we want to leave, it's kind of like in high school where we showed our work. We always want to do that because that can help if we're having a problem. I know at IndyVet, there was a situation where our insulin administration wasn't working appropriately. And we did find out that there was an inappropriate administration when making the insulin bag. And the key is if we had written down exactly what we gave, it would have saved some time in figuring out that it wasn't appropriately created. So by showing your work and having exactly what you added and what the expected concentration should be, it's going to help us in the future make sure that we are giving the right medication to our patients. And that also segues into the 7 rights for appropriate therapy. So this was actually from human medicine as well. A lot of things we do in vet med is extrapolated from that. But 1/3 of all medical errors or medication errors causing harm to a hospitalized patient occur in the medication preparation and administration phase. And that is predominantly a nursing activity in human medicine. And similarly, in veterinary medicine, it is commonly a technician-based activity. I know especially in the times of COVID, our clinic is absolutely just busy as all can be, every night and day. But it's really important that we go through, and in human medicine, they found the 7 rights are ways that we can just try to confirm for each patient that we are giving them the appropriate medications. And so the 7 rights are, you want to make sure when you're going to give something or start up a constant rate infusion to a patient, you have 1, the right patient, 2, the right medication or right drug. 3, confirm that you're giving the dose that is expected. 4, ensure you're giving it through the right route of administration. 5, make sure that we're giving it at the right time. 6, we want to make sure we're giving it for the right reason. And 7, we always need to document. And that goes into our appropriately labeling, whether we have putting the label on our medications, and also ensuring you put it into the patient's hospitalization log. So we use SmartFlow. I'm sure there's other paper records or whatever system you use. We need to make sure all these things are done. And they did find, in actually one of our M&M rounds recently, we talked about how in human medicine now they're trying to stop interactions with technicians or individuals who are in the middle of a medical population event. And so in some cases, it may be appropriate if you are setting up a constant rate infusion and someone comes with a question, unless it's an emergency, you should probably tell them, hold on, I'm making this, and go through the 7 rights before. That way we can try to reduce the risk for error here. The last thing I'm going to cover before we jump into far too many calculations is constant rate IV line maintenance, just things that are going to be good for maintaining and setting up kind of the last bits of your line. So it's really helpful to know what your line volume is, because that is going to give you an idea of the lag between when you change a fluid rate and when you're expecting to see that outcome. It should be labeled on each of your spikes or sets, or if it's an extension set, but the Baxter spikes we have at Inuvet are 10.5 milliliters in the line primed. The Zoetis extension sets are about 4.4 milliliters. The key of knowing these is if you're going to change your fluid rate or your medication rate, there's actually going to be somewhat of potentially a delay, depending on if you're using a syringe pump, that medication is going to be delayed from the location of your piggyback to the point of your patient, partially based on the total fluid rate that you're on. So those are good things to keep in mind when you are giving a CRI, that you may not get that instantaneous reaction from your dose change based on what the distance is from where your piggyback enters in and where your patient kind of goes, or how long the distance is between that piggyback and your patient. Other things which we should just know, but it's good to go over, is purging air from the line. In some cases, a small blip isn't a problem, but generally you want to purge that. Aseptic technique at all times. We always want to assure catheter patency. We did talk about the distal occlusions, and that is something, whether it's us accidentally, leaving something clamped, if it's a patient movement with a leg, or if it's not patent anymore, these things can definitely affect the medication administration. I want to be checking for phlebitis and fat thaw. And 2 things that I really think are important is whenever you're going and restarting a constant rate infusion, or any fluid for that matter, always double check exactly what the rate should be. Don't just restart what the last setting was. Ensure that that is appropriate for what this patient should be receiving. In some cases, they may have just received a bolus, and if you restart them on the same rate, they may be getting a bolus then for the next hour, which is probably not appropriate. Similarly, with light-sensitive solutions, we need to be very careful. So a good thing to keep in mind, because I can sit here and tell you, well, this and this and this are all light-sensitive, so we need to wrap them up. But good thing to keep in mind, if it comes in a darkened vial, it's probably light-sensitive. Lidocaine, metoclopramide, those are the first 2 that always come to mind. I believe dihydramine as well. But the big thing is if it comes in a dark brown bottle, it's probably light sensitive. And that's a good place to start for all of those. Things that we do is you can wrap it in tape or vet wrap. I would say if you're using vet wrap, make sure that it's double layered thick enough to actually protect the line. And other things you want to look for are also if some medications are actually going to kind of bind to the plastic in the line. So diazepam is one that you will find that you should prime the line and then reprime it, because it will bind to the line itself. Here, I just have some, so these are actually taken from an anesthesia book. These are general doses, but this way, if you want to take a screenshot, so at least you have something to base this off of, or I can just get these files to you guys after this presentation. But it's a good thing to, it just has the loading dose that you need for any of these medications. So we always want our loading dose, and then we have our constant rate infusion dose, and then some comments about whether they need to be reconstituted, light sensitive, or other things that are important to know for them. Here are some other ones. So I have those 2 pages, and these are just the general doses. Of course, a veterinarian may choose, depending on the patient, for intraoperative, fentanyl may need to go up higher. And the other thing that's important, which unfortunately I was limited in time with this discussion, but I have some slides also just on things to keep in mind. So whenever you're administering a medication, you always want to know what are the side effects that we're going to be expecting. Our opioid-based medications, we're going to be having respiratory depression. This is something that we can see. Or if you're giving, something like morphine or hydromorphone, we may see actually histamine release if those are given too quickly. And so it's just really good to know what our side effects that we can expect are for the specific meds. All right, so here is the fun part, and that was sarcasm. Calculations overview, and as we move into the more math portion, unless you like math, in which case I'm sorry for hating on you. I'm kidding. So we're going to cover some fundamentals, just review over some algebra and stuff from high school or college, and then we're going to go into some practice. So effectively, when we're using calculations, we have certain units of measurement, mass, time, volume, and generally that's going to be grams, kilograms, micrograms, milligrams. Time, we have seconds, minutes, and hours, and volume, we have liters and milliliters. Generally, the units we're going to be using. And the goal, really, all of this comes down to is we have a unit of measurement. So in this case, usually that's what is the infusion rate. We want to give this patient 5 micrograms a kilogram an hour. And we have to convert that to how many milliliters of drug do we add to this bag? How many milliliters of drug do we draw up for this syringe? Really, all we're doing is converting units. That is effectively everything that's going on. But it gets very complex as we get more units. Here are some basic doses or conversions. So 1,000 grams are in a kilogram, 1,000 milligrams are in a gram, 1,000 micrograms are in a milligram. I always forget that 1% solution means 1 gram per 100 mils, or 10 mgs per mil. No matter how many times I read it, I have to go back to the slide to remember it. Same with a kg is equal to 2.2 pounds, and 1,000 milliliters is 1 liter. And I don't know why drops are GGT. I do, it's Latin, but the other thing I want to cover over is that, as you can see up here, for this presentation, and in general, what we can see is 10 mg per mil. That's how we write things. For a lot of these problems, I'm going to be writing it as 10 mg per over the mil, and that's going to help us just with the math that we're doing, because it gives us a visual representation of where that milliliter is for when we're canceling out units. Once again, our focus here is really we're doing algebra. We're going to try to find x. We're going to try to first reduce or the equation or isolate x. So in this case, subtract 2, x equals 3. Same thing if we're multiplying or dividing, we're trying to isolate x. So we're going to multiply 3 over 2 to get rid of our 2 over 3. Those are going to cancel out. 3 cancels out, 2 cancels out. Then we just simplify or reduce the equation. So 4 times 3 is going to give us 12. And that divided by 2 is going to give us 6. Perfect. And this is another thing I just wanted to touch on is, in case everybody forgets, and you don't have a fluid pump available, here are just some numbers for fluid pump settings. So on the off chance that you are out of fluid pumps, which in COVID times we have been, it's always good to know these so you can set up a drip rate in case you don't have one available. So let's get into the actual calculations. So generally, when we have a case, we are going to know usually our patient's weight. The doctor is generally going to pick an infusion rate that we desire, That may be mgs per kg per hour, it may be micrograms per kg per hour, but it's generally going to be some sort of mass unit per kilogram per hour. We're going to know our drug concentration, and generally we're going to know what our IV fluid rate is. So these are the things that we're going to consistently know. And the goal is we're trying to figure out how much medication are we going to add to the fluid bag or drop out. And there are different ways to calculate that. I'm going to focus on a simple pathway of we're going to start with our infusion rate. We're going to convert that to how much medication mg per hour, convert that to how many mils per hour. We may or may not need the duration of therapy if we're using a fluid bag, and that's going to get us the answer of how many mils to drop out. Now, these are calculations that we probably do fairly often without any, or with any case, but either way, it's good to just remind. So if we have or want to calculate the dose per patient, you multiply the weight times dose per kg, that's going to give us the milligram of dose. Similarly, if we're trying to figure out the dose per hour, really we just added in an hour, but it doesn't change that same equation. Same if we're trying to figure out our dose volume. We have our dose divided by our concentration will give us our volume. And the way that we can reformat that is, instead of having it explicitly written here, by having it in this way, we figure out these cancel out, which I guess I should have turned this to a multiply sign, so I apologize for that. But the key is by dividing by the concentration, we are inverting these units. So we're putting the milligrams on bottom, and we're putting the milliliters on top. Therefore, they cancel out, and that gives us the dose that we need. So we'll start off with a case. Lucky. Lucky is a 3-month-old female, intact, 5-kilogram mixed breed, and she's coming in for anorexia. We do a spot glucose and reveals that she is hypoglycemic. She needs to be administered a bolus of 50% dextrose at 0.5 milliliters per kg IV, and we need to dilute that. And then we need a 5% dextrose solution in a saline bag, 250 mils. So what do we do? Well, the first thing we want to do is pull out what are the important numbers. It's always the first thing that we should do. And the first thing we need to give this patient is that bolus. So let's take out what are the important numbers that really we take from this history in this presentation, and let's write them down. We have a weight, we have a dose, we have a concentration. Let's get our volume. The other thing we need to do is we want to get 10% solution from 50%. So we're going to use this equation. Now, it takes an initial concentration of our initial, or so in this case, C1 is that concentration, and V1 is our initial volume, and we're converting it to a new concentration. So because concentration and volume are inversely related, if you increase one, the other has to decrease, and that is as long as you're not adding necessarily more of the mass to the equation. So we can use this for our dilution. So let's try it. So first things first, how much bolus do we need to make? So if we need 50% dextrose bolus of 0.5 mils a kg IV, let's figure out how many milliliters that is. So in that case, our volume is going to be 0.5 mils a kg times our 5 kilograms. Our kilograms are going to cancel out. That'll give us 2.5 milliliters. But now, we know we need 2.5 milliliters of 50% dextrose, but we want 10% dextrose in our solution. So we're going to use our equation for that. So on the left side, we know that we have 50% dextrose, and we know we have 2.5 mils of that solution, and we want 10%. So that's what our C2 is. Now, as we refreshed over, we're just going to reduce the equation. So we're going to divide 10% on each side, where 10% is going to cancel out. Our percents will cancel, and that leaves us with 50 divided by 10 times 2.5. 50 divided by 10 is going to be 5, and that multiplied by 2.5 is going to give us 12.5 mils of 10% solution. Now, how do we get 12.5 mils from 2.5 mils? The key is we're keeping the dextrose in the solution the same. We're just adding saline to make up the difference of volume. So we will just find the difference, which 2.5 minus, or 12.5 minus 2.5 is going to give us 10 mils of saline. So we know that that is our bolus. But now we need to get that 5% dextrose solution. So first thing we're going to do is actually use the exact same equation. Because really, we're just converting from 50% dextrose to 5% dextrose. The key, though, is before we knew what our initial volume we wanted was, now we don't. We know we need 250 mils of a 5% dextrose solution, and we're starting with 50% dextrose. So how do we get there? We're going to use the exact same equation. So 50% times our unknown volume is going to equal 5% times our 250 mils. We're going to do the same thing. We are going to decrease this equation, or reduce this equation by dividing by 50 on each side, 50%. 50% is going to cancel out. Our percents will cancel, which leaves 250 divided by 5 times 5. 250 divided by 50 is 5 times 5. That's going to give us 25 mils. So what does that tell us? It tells us that we need 25 mils of our 50% dextrose for this. But there's one more step that we always have to do when we're working with a fluid bag and we're adding medication. You always remove the amount of fluid that you're adding. So we're going to first remove 25 milliliters from the bag, and then we will add 25 mils of 50% dextrose. And that gives us our solution. Now, I do have to ask, does everybody here have some paper and pencil to write on? Because we're going to do just a little bit of math here. Because now that I've covered over how to do this, if I can get my screen to go forward, I'm going to let you guys do this. So I'm going to give you just a little bit of time. We're going to do the exact same thing, but now we want to make a 2.5% dextrose solution. So I'm going to give you just a minute to go ahead and try the math, and then we'll go through this together. Because we're doing the same thing, but now we want to make a 2.5% dextrose solution. All right, so doing the same thing we did before, we're going to divide each side by 50%. 50% is going to cancel out. Our percents will cancel. That's going to give us the same 250 mils divided by 50. It'll be 2.5 times 5. It'll give us 12.5 mils. Once again, 250, and we have 12.5 mils that we want to add. Therefore, we will remove that, and then we will add 12.5. All right. Now, I was informed that we're not actually taking questions until the end of this, but I just wanted to put in a cute winking dog. But if you have any questions, you can absolutely put those in about that. That way Mariah can hopefully let me know in case there is anything that wasn't made clear there. But the things that we want to take from it are, we want to extract the important values from our equations. As long as we're not adding new, so we're not adding more dextrose necessarily to the solution or more of our medication, our concentration and volume are going to be inversely related and maintained. So for making any new concentration, you can always use this equation. And always remember to remove fluid from the fluid bag equal to the volume of the fluid that you're going to be adding. So now I do notice this is taking a little bit longer than I was anticipating. So I'm actually going to try to skip through this one because this is taking a little bit longer than I anticipated. And we're going to skip over to the next case. So I'm sorry that you all don't get to do all of this lovely math with me. But we're going to focus on Hope here. So Hope is a 5-year-old female spayed, 10-kilogram beagle. She's presenting for whatever painful thing you can think about. And you've been instructed to prepare a morphine CRI for her at 0.3 mg per kg per hour. And she's going to be receiving fluids at 50 milliliters per hour, or 5 mils per kg per hour, with a new 500 ml bag of lactated Ringer solution. So the first thing that we want to do is pull out, once again, what are the important values that we get from this equation. So I've highlighted those, and then we're going to put them down below. So we have a 10-kilogram patient. Our infusion rate is going to be that morphine at 0.3 mg per kg per hour. Our concentration for morphine is 10 mg per ml, and our fluid rate is going to be 50 mils an hour, or 5 mils per kg per hour. Let's begin. How many mgs per hour is going to be our first step in conversion, which is going to tell us then we're going to convert to how many mils per hour. Then we're going to figure out how many hours this fluid bag is going to last us, because once we have all that information, we can figure out how many mils of morphine we need to add to our fluid bag. So for Hope's case here, the first thing we're going to do is try to figure out how many mgs per hour of solution we're going to be using. So we're going to take our infusion rate, and we're going to multiply it by our patient's weight. Our units are going to cancel out for kilogram, and that's going to give us 3 mgs per hour of morphine. Now we want to convert this into a solution. So we know our concentration is 10 mgs per mil, and we know that we want to try to convert this to milliliters. So we're going to start with our 3 mgs per hour, and we're going to divide by our concentration. In this case, we're going to take our concentration and inverse it. So we're going to put 10 mgs on the bottom. We'll have 1 milliliter on the top because it's 10 milligrams per milliliter. Our units are going to cancel out, and that's going to give us a nice 0.3 mils of morphine per hour. So the next thing, though, is we know that we have 0.3 mils of morphine that we're giving each hour. But we don't know how long this fluid bag is going to last us. We know that we're using a 500 milliliter bag, but we don't know how many hours that we're going to be using that. So let's figure that out. We're going to take our fluid total, and we're going to divide it by our fluid rate. And then we're going to figure out 500 divided by 50 will give us 10 hours. So that gives us all the information we need to figure out how long this fluid bag is going to last us and how many mils an hour we need of morphine. So we'll just put those things together. And that's going to tell us that for this patient, we're going to need 3 mils of morphine per 500 milliliter bag. But the one thing we always got to remember is that we need to remove the amount of fluids that we're going to be adding. So we'll move 3 mils, and then we will add 3 mils of solution to the bag. Now, that did seem like quite a bit of math to go ahead and just figure out for a fluid bag here. So I'm going to show you a shortcut now that Amanda Shelby showed me. So this only works for if we're adding to a set fluid volume. It works best for fluid bags, though I suppose you could use it for another substance or another any fluid volume as long as it's staying the same. But remember, all we're doing is taking units and converting them into the units that we want. So I'm going to take the infusion rate, I'm going to multiply it by the total volume, and I'm just going to divide it by our patient's fluid rate. And the reason that this works is because if you look, all of our units are going to cancel out very nicely, and that's going to tell us our dose. And then all we need to do is convert that to what our dose volume is. Instead of the 4 steps it took before, we really have 2 now. So let's try this out with the same patient. The one other thing I did want to mention is if we don't know what our fluid rate in mils, this should be a milliliter. So I'll just draw that in. That should be milliliter. So if you don't know what your patient's fluid rate in mils per kg per hour is, you can just take your fluid rate of mils and divide it by the patient's weight, and that'll give you that answer. So we're going to try that here with HOPE, but we're going to use our shortcut instead, and we're going to see how that works. So we know HOPE's infusion rate is 0.3 mg per kg per hour, and we know the total volume is 500 mils, and we know her fluid rate is 5 mils per kg per hour. So if we do that, our units are going to cancel out very nicely. And then we're left with 0.3 times 500 divided by 5, which, if you have a calculator on your computer, a laptop, you can find out pretty readily, and it's going to give you 30. All we have to do then is take our 30, convert it, but with our concentration. So once again, we're going to take 30 milligrams, and we're going to divide by our concentration, because that's going to give us what our volume is. And that'll give us our 3 mils of morphine, which is exactly what we just saw before, but this is a bit quicker. So we're going to go ahead and do that. But always remember to remove whatever volume you're going to be adding to your solution. So we're going to do the same thing, but let's try it on another patient. This is Stella. Stella is an 8-month-old, 24 kilogram, female spayed Rottweiler who's presenting for vomiting and diarrhea. She was hospitalized on intravenous fluid therapy at 120 mils per hour, or 5 mils per kg per hour, with metoclopramide added at 2 mg per kg per day, and a 1,000 milliliter bag of lactated Ringer solution. And we do know metoclopramide's concentration is 5 mg per ml. So, first thing we want to do, what are important numbers? Let's highlight them, and let's pull them down. Perfect. So now, we're going to use a similar method of the old type. So we're going to use our long way first, and then we'll use the shortcut again, because we want to make sure that the shortcut works. So let's do it. So the first thing we need to do is convert our 2 mg per kg per day into our rate of how much we're going to be having per just total mgs per day. So that's going to be 48 mgs because we multiply by 24 kgs. But now we really want to convert this to how many we're giving in an hour, because we generally don't give medication on a per day basis. So we're just going to divide by 24. And that's going to give us a nice answer of 2 mgs per hour. Of course, we're going to convert that to a milliliter solution. So let's take our 2 mgs an hour, divide by our concentration. Our units are going to cancel out. And that's going to give us 0.4 mils an hour of our solution. But we still need to figure out how long this is going to last us. So we have our 1,000 milliliter bag. We're going to divide by our fluid rate, which is 120 mils an hour. Our units will cancel out, and that will give us 8.3 hours. The last piece is putting those two together. Our milliliters an hour multiplied by the amount of hours tell us for this fluid bag, we are going to need 3.3 milliliters of metoclopramide moving forward. And always, if you are adding 3.3 mils, you need to remove 3.3 mils first. Oops, sorry. All right. Should I be answering questions right now?
Oh, yeah, so we have two questions. The first one is if you have a small volume of medication that you're adding to IV fluids, will you still remove the volume amount from your fluids?
If you're using a small volume, in which case we're saying like 1 milliliter per 1,000 milliliters, we may think inherently it's not going to make much of a difference, but for consistency, you always should. You should always remove the amount that you're going to add, because otherwise you do have a wrong concentration. And that can be very important depending on which solution you're working with. So yes.
Right. All right. And then the next question is, could using a burette be utilized for changing in doses for infusions?
Be utilized. Could you say that again?
I think they're wanting to know, like, could you use the burette system for fluid bags for changing volumes of medications?
For changing the volumes, I don't think so.
If there's any other questions, if you want to write them now, we'll answer a few more and then we'll get off of here. Thanks, guys.
Oh, I was going to do one more. I wasn't entirely done.
Then go right ahead.
Okay, cool. So basically this next part is I was just going to try to, I saw the question pop up, so I felt it important to try to help answer that in case it would help clarify anything going on. So I'd like to do just the same thing we did. We already know the answer here is 3.3 mils, but we want to, make sure that you guys understand the shortcut method, and to confirm that the shortcut method works. I do know it works because I've used it multiple times and it is efficacious, but if you're getting a new shortcut, you kind of want to test to make sure that it is consistent. So we're going to do the same thing, which is the infusion rate times the total volume times the fluid rate. I'm going to give you just a few minutes to go ahead and do this yourself. So we're going to do it again with this patient, but the great thing about this equation is that you can use it with any volume of fluid, which we'll show in just a moment. So for this, we're going to go ahead and get that set up. And I am letting everybody else try this first on their own, if you feel comfortable. The one thing we do want to keep in mind, though, is we always need to have our units matching. I do think this lecture would probably be better if this were all in person, because then I could give instant feedback to anybody in the room doing the math actively. So I'm unfortunate that we're under these circumstances. So that was a little bit of time. I'm not sure if everybody's done, but we are under time constraints. So I'm going to run through this with you guys, because it's this slide, and then I have one more, basically the same equation that we'll go through as well, just to show you how handy this is. So the first thing we want to do is we actually need to get our infusion rate and our fluid rate on the same units. So if you look, we do have our infusion rate is in mg per kg per day, and our fluid rate is mg per kg per hour. So we're going to normalize that. You can either change your fluid rate to per day, or you change your infusion rate to per hour. In this case, I elected to change the fluid rate to mils per kg per day, but you can do whichever one you feel more comfortable with. So I just multiplied by 24 hours. The units canceled out. So that gives us our 5 milliliters per kilogram per hour is the equivalent to 120 mils per kg per day, because we're converting 24 hours worth of fluids. So that's going to give us 120 mils. And then I just insert that into our lovely equation here, which is 2 mg per kg per day divided by 120 mils per kg per day, multiplied by the 1 liter or 1,000 mils that we're starting out with. Once again, our units are going to cancel out very well. It's going to give us 2 times 1,000 divided by 120, or if we kind of take the 2 and 120 down, it's 1,000 divided by 60, which is going to give us 16.7 mgs. That divided by our concentration, once again, we have our dose, which is 16.7 mgs. We want to divide by our concentration, because that'll give us what our volume is. And that's going to give us, if this works, 3.3 mils, which is exactly what we measured before. So we've proven, once again, this does work. Give us the same answer, but potentially in an easier way. The last thing you may ask is, once again, of course, I'm going to remove that 3.3 mils. The last thing you may ask is, what do we do if we have a patient who's already started on fluids? And that's actually something we commonly have. We'll have a parvo patient, or a patient who's been hospitalized for potentially an obstruction. And then we get them on some fluids. We maybe recheck x-rays, you do an abdominal ultrasound, and you notice that, wow, they aren't obstructed, but maybe they have some really bad ileus. Maybe they need some metoclopramide on hand because they're a parvo kid or something. So what do you do in the case that now our fluid bag is at 790 mils? The great thing about this equation is you don't change anything except the fluid volume that you're starting with. So you do the exact same equation, but you just change this right here. So it's very helpful for if you already, or you have a bag that is already used some. I know that's where some people get nervous, because then it's at a different volume you're starting with. But you can do the same equation. The units still cancel out the same, and that's going to give you the same answer, which is 2.6 mils, and then once again you want to remove. So sorry we kind of breezed through this, and unfortunately I know it's a little hard to do math over Zoom, but I am more than happy to stay after and answer some questions for you guys if people want to stay on, and hopefully I can clarify anything. I guess just for closing is, big thing with constant rate infusions is that we have syringe pumps and fluid bags. We're aiming to stay within that therapeutic range. Thing we can do is give a bolus and then use our constant rate infusions to stay in that therapeutic range. For calculations, we have our handy dandy concentration equation that's going to give us our C1V1 equals C2V2. Always just look for your units of measurement. That's all you're doing here, is converting the units you have into the units you want. Find X, isolate, simplify, and of course, this is going to be our handy-dandy shortcut equation for moving forward. With that, basically, this is the end. I did want to thank Dr. Gillespie, because she's amazing and helps out with everything, with all of the endeavors of setting this up. Dr. Robertson, who really helped out with first year of internship, and then Dr. Mosin, who's been my mentor along the way, being really supportive and actually helping me figure out how to set up the crossing out of the units. Amanda Shelby has been invaluable. If you ever have any anesthesia questions, she is above and beyond amazing. I did want to thank my intern mates. I know I've graduated my internship now, but they were also very helpful in supporting me along the way, and just IndyVet in general. We have an absolute amazing staff, and I want to thank all of our technicians who are the lifeblood of IndyVet. For everybody out there, I'm willing to stay a little bit after and help you out if you have any questions here. And then otherwise, that is all of it. The last thing I have is just some citations of the many resources that I used.
Thanks, Dr. Kuechle. There was no more questions. If anybody had any, if you want to write them in the Q&A. Just to let everybody know, you will be getting your CE certificate emailed to you, probably either tomorrow or by the end of the week, you'll have them. So if you have any questions or concerns, just let us know. You can send the email to the admin at IndyVet, and she'll get with Dr. Kuechle on any questions you have.
If nobody else has any questions, you can always email Mariah if you have any more, or you can, I guess, email me potentially if there's anything I can answer. Otherwise, thank you all for suffering through math with me, and I hope you have a great night and great rest of your week. Take care.